Hello, everyone. Welcome to Room Now's Rheumatology Roundup from ACR 2024, where we present highlights of the annual convergence meeting that just ended and was in Washington, D.C. I'm Jack Cush with Room Now.
Artie Kavanaugh, and as you can see, like all of y'all, I'm back at work after a very busy meeting in Washington, D.C. A lot of material, that's for sure.
Yeah, we're home recovering from what was a really big, great meeting. We'll be discussing abstracts and presentations from the meeting. These were chosen without influence of peers, family members, or professional marketers. Our content is solely based on our interest in the research, maybe its impact and innovation in practice. This represents our uncensored views on these topics. Reproduction of this award-winning podcast and broadcast is not advised unless you're looking for a whole lot of trouble. Artie, I'm told that this was one of the most attended meetings since the pandemic, and that this year there were more U.S. Attendees than outside the U.S., and that was sort of a new change. What do you think about the crowd?
Yeah, it was good to see. We've been doing this, what, Jack, since 2005, and the heart of the meeting is really the posters. And every convention center has a different layout and different rooms and lectures and stuff, but it's really the posters. That's where I gauge the crowd. And it was nice. It was a pretty good crowd there in the going poster to poster, walking right up, getting to meet the people who are trying to defend their most recent work that they were presenting at ACR. So it did look like you came back to maybe the pre-pandemic levels, and that's a great sign.
Yeah, I think so too. So, Artie, why don't you start us off with one of your favorites from the meeting?
Okay. Uh, I'm picking abstract 1679, and this is the amplified study. The reason I picked this is that one of the topics that we're very interested in is predictors, biomarkers, personalized medicine. What is the right drug for the right specific patient? And largely, we don't know. And Jack and I both went over all the abstracts for the meeting ahead of time, and there must have been 100 on predictors of response in rheumatoid arthritis and in other diseases. And we always want these to be something promising. We want a test that will tell us that Mrs. Jones should get drug A and Mr. Smith should get drug B based on either efficacy or safety. So, gosh, we looked at a lot of these. This one looked at this amplified study. Now, we've seen the clinical data before, and that is that it's a head-to-head study, abatacept versus adalimumab, ACPA-positive patients with early rheumatoid arthritis. Over 24 weeks, boy, there was not a lick of difference between them. So both did well. A lot of people responded. ACR 20, 50, 70 responses were great. This was a biomarker poster, and they looked at changes in circulating peripheral cells. And they found some big differences. They found some very distinct differences, particularly in B cell populations. So the patients treated with abatacept, not only did they change their seropositivity, their titers of CCP and rheumatoid factor went down, but they also had an increase in the number of circulating B cells and the number of circulating T cells as well. The adalimumab group had a greater increase in certain subsets of B cells, and the responders to adalimumab had an increase in Th1 and Th17 cells, and also class switch memory B cells and plasmablasts. So on the one hand, you have clinical the data, which are not different between the two. The hope had been that you might be able to predict which patient was going to respond to which agent, and you can't. There are these nice changes, but none of them correlated with efficacy. None of them correlated with tolerability. So in all of the abstracts that we looked at that went for predictors, and the methods have gotten just so incredible these days, especially things like spatial transcriptomics, where you can look at a biopsy of an inflamed synovium and look at what cells are present, where they are, and how close they are to each other. It's just fascinating, but we're still missing precision medicine. So I think we're just going to have to keep looking for that at future meetings.
So the great hope of this amplified study was really based on the APIPRA and ARIA and other studies in patients with not yet established RA, clinically suspect arthralgia, preclinical RA, where you gave abatacept, and they did really, really well compared to really nothing. And there, the biology of preclinical disease is certainly different, and maybe going after T cells with abatacept made a difference before you established these. These patients were early RA, and they were double positive for RF and ACPA, and two-thirds of them were shared epitope. And the great hope here was that ABBA would distinguish itself compared to ADA, and it did not. And so the question for me is, maybe it doesn't matter after you already have established disease. Maybe the only difference here is between what you choose is before they get established disease, or maybe these changes that you find biologically, mechanistically, might they mean something, 2 years down the road? We don't know. And this trial didn't fulfill any promises for us.
Yeah, we're still lacking. Do you think back many years when you looked at the synovial biopsies, and a consistent feature of responders was a decrease in the sublining CD68 positive macrophage population? Very crude back then, before we even knew much about macrophage subsets. But that just went along with response, and it didn't differ by what the treatment agent was. So as much as we have some really cool methods now and some very beautiful illustrations, we're still lacking something of clinical utility.
Yeah, I remember Artie and I were walking from one of these great presentations about biomarkers and proteomics and transcriptomics, and he said to me, "Isn't this the data we saw 20 years ago about the changes in the synovium?"
Yeah.
And Artie, what do you get from your conversations with Hani Gabaloy and others?
Yeah, he said it certainly rings very true. We know a whole lot more. We know a whole lot greater detail, but we're no further down than we were in some ways by looking at those gross methods that were used decades ago.
Right. Yeah, histochemistry was all we had. Now we got all these sexy things, which are really cool, but I don't think it's getting us the answer that we want. My first one is also on RA. I have this preoccupation with seronegative RA. It's a bother for me every time I see one. This is a follow-up, and it's really good data. It comes from Mayo, abstract 0458. And this is a 20-year follow-up study of 176 patients with seronegative disease, and they were double positive. I'm sorry, double negative. They were mostly female, over almost 12 years of follow-up. And the interesting thing in their data, it differed from other data. Other data would show that somewhere between 40 and up to 65% of patients who are seronegative might change their diagnosis if you follow them out 10, 15 years. In this study, with again almost 12 years of follow-up, the 10-year cumulative rate of change in diagnosis was only 15%. And that number, which was about I think a third or 40% of them, were either spondyloarthropathies or they turned to seropositive RA. 11 spondies, which is PSA and AS, and then 6 became seropositive RA. 5 were OA, 3 crystal arthritis, 3 CTDs, I don't know what that is, and 1 each with infection, paraneoplastic, RS3PE, or sarcoidosis. Of those who stayed or didn't change diagnosis, 27% went into remission within 10 years. And then those who stayed with a diagnosis, about 20% required future treatment with aggressive therapy, biologics or targeted synthetics. So maybe fewer people changing over time. Maybe Mayo, they're a little bit better at diagnosing seronegative RAs than other places. But I think it's important to note that this could be the fate of patients who have seronegative RA.
Yeah, one of our colleagues, Moran Bakari, a great doctor from the UK, said, well, maybe we shouldn't put seronegative patients in studies. But that's a very, very different consideration, because when you put somebody in a study, you require that they have multiple swollen joints, you require that they have erosions, you require that they have other factors that make them worth treating. And if you think back, way back when we started the first studies in biologics, a very long time ago, if you look in those studies, the seronegative population, they had serious RA. So this is very different. This looks at the population level, and yeah, it's a mild disease, a lot of drug-free remission, a number of people who change diagnosis. So it's a quirky subset.
If you look at any clinical trial, you'll see often at the end of a clinical trial, there's 1 or 2 people who actually did change their diagnosis, and that's not uncommon. And the other thing about the dynamics of change here, these changes were not within the first 12 months. A lot of them were delayed over 5 years, if not more. So it does take time, and it's going to happen. So you do have to keep an eye on what the fate of a seronegative RA is going to be.
All right, so my next presentation is abstract 0082, and it's a basic science abstract, but I think we like the basic science abstracts when they have clinical implications. So this is comparative immunology of enthesial anchorage sites between spine, hip, and knee. So if you think of the SPA group of diseases, axial spondyloarthritis, psoriatic arthritis, inflammatory bowel disease, they share many common features, including the putative role of IL-23. And you see this in the genetic changes, you see this in the tissue expression among these different diseases. A big puzzle to us then has been the fact that inhibition of IL-23, which is super effective in the skin of patients with psoriasis, is not effective in axial arthritis in ankylosing spondylitis or radiographic axSpA. And that's puzzling. And there's been some conjectures, but this was a nice study, I thought. This came from Dennis McGonigle's group in Leeds, and they looked at the tissue specimens, and they got these from the spinous process, they got them from the hip capsule, and they got them from the knee. And they looked at perienthesial bone immune cells. This is all during orthopedic surgery. When they look at these cells, what they found is that non-stimulated, all the tissues made a certain amount of IL-23. They were all capable of producing IL-23. But when you stimulated them, the spine and the hip, compared with the knee, produced much more IL-23. And there are also some differences. It was more the inflammation, the monocytes and neutrophils are more abundant per gram of tissue in the spine and the hip, in the red marrow, but not in the yellow marrow of the knee. So the clinical implication of this is that maybe IL-23 inhibition maybe we haven't studied the right dose to see if it's effective in axial spondyloarthritis. And there's some rationale to that. You think of data with the TNF inhibitors, where at the PSA doses where all the agents are great, the skin doesn't do as well with the etanercept. You need more of that. So I thought this was intriguing.
It certainly is a good explanation for maybe why we see that treatment difference when you might have expected IL-23s to work. And there is some preliminary data about psoriatics with spondy where they might respond to IL-23. So I think it's exciting, but no one's tested the idea of more drug as a potential answer. So we need to see maybe by next year whether that'll happen.
There are a couple of studies in psoriasis looking at much higher doses. The idea being that if you treat early psoriasis, maybe you can knock it out. Maybe you can hit it very hard and have a very prolonged clinical response. So yeah, maybe we should do those kind of studies in axSpA.
Cool. All right, I reported on this before. I just can't let it go. Emapalumab in Still's disease. This is a late-breaking abstract, L19. We've talked about it. 1 year it was 9 patients, another year it was 12, and then it got up to 15. Well, now they've kind of combined a clinical trial with an open label prospective trial, and they've got 39 patients, all Still's disease, kids and adults who have serious macrophage activation syndrome, not responding to conventional therapies. And I think this is critical because I think they have a critical mass on a drug that's already approved. The drug is emapalumab. It's marketed as Gamifant. It is a neutralizing anti-gamma interferon monoclonal antibody. And now with 39 patients on an already approved drug, I think they got enough that could become an FDA-approved drug to treat MAS that occurs in Still's disease. Why? Well, it's a 20 to 40% mortality rate when this does occur in either kids or adults. So they could pool the data. They got 39 patients. They have a scheme which is different as time goes on as to how you dose it. The primary endpoint was a composite of 8 clinical measures were designed to basically show the kind of things that you'd expect to see, cytokine storm or macrophage activation syndrome. If you met all 8 of those criteria, then you were a complete responder. In the trial, however, only the first time out, I think the number was something like, I wrote it down here, was 53 4% when with that definition of primary endpoint. But if they just dropped the LDH, which turned out to be non-predictive, going with a 7-point measure for meeting complete response, it now responded by 76%, with 82% showing MAS remission by the investigator. All the things you'd want to happen happened. Steroid tapering was dramatic. Circulating IL-2 receptors dropped. Ferritin levels dropped. All the things that you'd want to see, LFTs, etc., all became major, pretty fast responders within the first 2 weeks of this therapy. I put it out there because I think it's a game changer when it comes to how these patients will be treated in the past. In the past, it was you give them steroids, you put them on an IL-6 or an IL-1 inhibitor, and then depending on who's involved, they're either getting cyclosporin or etoposide, and the responses are kind of, never quite. Seems to be so much better. But I think it's a game changer for the future.
Yeah, the cyclosporin and the etoposide, those come from the heme people, the cyclosporin. I think we know how to manage the etoposide with a neuropathy. Boy, that's a tough one. And yeah, when these people come in, they're super sick and they get everything thrown at them, like kitchen sink approach, basically.
Right.
So something more focused and more mechanistically relevant may be good. And the tolerability it seems reasonable. Yeah, and I think back a very long time ago, interferon gamma had been targeted in rheumatoid arthritis studies, and it just didn't work. It wasn't the right mechanism, and I don't believe it was beset by a lot of complications necessarily. So yeah, this is something it'd be nice to have for a small but important subset of patients for sure. All right. My next one, I got to say, as we went through the abstracts, what were there, 2,700, Jack, or 29? Yeah, if it was a contest among the diseases, and of course there's no contest and there's no gambling, but lupus was the winner. Lupus was, my gosh, lupus was everywhere. You think back to the ACR years ago, we were begging for things for lupus. Now you have all sorts of therapeutic interventions. And as always, when you have the therapeutic success, that drives further research into diagnoses, into stratification, into looking at other outcomes, creating novel outcomes. And boy, there was a ton of stuff in lupus. I had a medical student here in clinic with me yesterday, and he's a third-year medical student, has kind of an interest in rheumatology, but he said, hey, there were a lot of CAR T abstracts at the ACR. I was like, well, good on you. How did you know that? But yeah, CAR T abstracts were everywhere. I didn't pick one of those to highlight because I think they're all they're super exciting. Maybe there's something to there, but we don't have controlled data on them, and we may not have controlled data. Also, I don't know if the CAR T, I don't know if that's going to persist, meaning we have better ways to target B cells. We had rituximab. Well, now we have obinutuzumab, but we also have these bispecific T cell engagers, tri-specific T cell engagers.
Bites and trites?
Bite, well, you can't say bite though. That's a trademark. So now we're going to have to pay. But the bikes, yes, you can say bikes and trikes and cars. I mean, the CAR T thing lends itself to lots of funny names and stuff. I don't know where there's going to go, but my abstract was number 1553. This is from Yoshia Tanaka, his group in Japan. This looks at an oral antagonist of toll receptor 7 and 8. Small molecule, very selective in its binding. Of course, toll receptor 7 and 8, very reasonable targets in lupus, which we know from genetic studies in looking at the proclivity to develop lupus. And also, they're very intimately involved in the immunopathophysiology as we understand it, with the changes in nets and self nucleotides activating the plasmacytoid dendritic cell, elaborating a lot of interferon, and that activates a lot of downstream effectors, which give us many of the manifestations of disease. This was a relatively small study. It had basically two studies they combined here. This looked at placebo versus 100 milligrams a day versus 200 milligrams a day. But they had a very clear differentiation from placebo, especially at the higher dose. So they looked at the BICLA, the British Islands, the CLASI, which is a cutaneous, and the CLASI activity score. Again, mostly focused on a very small number of outcomes. Skin, arthritis, also looked at double-stranded DNA and complement levels. Tolerability wise, there's a little bit more, but nothing more than a class 2 AE, a little bit more in the higher dose. So very exciting, and it's oral. So among all the therapies that we have for lupus, I like this one because it kind of fits with what we think of as the pathology, and it looked kind of cool. Small numbers, need a lot more study.
Yeah, that's what I noticed when it was presented at EULAR as a first run, and then also here. The numbers are low, but they're really encouraging. We've been talking about toll-like receptors for a while. Mechanistically thought to be one of the mechanisms of hydroxychloroquine effects in lupus. But I like the approach in that it's oral. Seems to be well tolerated. You're really dying to see what a phase 2 is going to look like in this with 200 or more patients in a trial. That would be really exciting. Okay, so lupus was the bomb at this meeting, and a big event was the rollout of the 2024 ACR guidelines, updated guidelines on the treatment of lupus nephritis, presented by Lisa Samaritano, Maria Delaria, Anka Askenazi from New York, and Maribeth San. They all did their different parts of this. Large effort, many different committee members. I like that there was kind of a simple version of this. And I'll give you the simple version. One, everybody gets a renal biopsy. Surprising? Hello, I don't think so. But new diagnoses with more than 0.5 grams of protein or flares, get a biopsy is what they say. And then the treatment was based on whether you had class 3-4 disease or class 5 disease, or whether you were a kid. I'm not going to cover the kids. But everyone, and by the way, all these recommendations are expert opinion. They're conditional. None of these have strong evidence. So you can argue with us all you want, but nonetheless, the lupus experts of the world are unified in this approach, including the Nephrology Society that was represented on this committee and in this presentation. One, everybody gets prompt glucocorticoids. They get pulse steroids, 250 to 1,000, 1 to 3 days in a row, started on 40 milligrams, and then weaned down to 5 within 6 months. Everybody should be on hydroxychloroquine. You have to put everybody either on an ACE inhibitor or an ARB. And then they basically say that if you're class 3 or 4 disease, you need 3 to 5 years of triple therapy. They consider steroids part of triple therapy, which I find goofy, but nonetheless, triple therapy, which would be steroids, and then the other two options are either mycophenolate and belimumab as one option, or mycophenolate and a calcineurin inhibitor, another option, or the urolupus nephritis cyclophosphamide dosing regimen with belimumab. And overall, they tend to really prefer regimens that have mycophenolate rather than belimumab in them. But if you've got a lot of proteinuria, they do recommend the calcineurin inhibitors. And Artie, you were the first back when we were at Southwestern using cyclosporin in lupus, and then tacrolimus, and now we got voclosporin, a much safer option that's in this mix here. If they say if you have extrarenal disease with class 3 to 4, they like you to use belimumab. Then they go to class 5, and that was presented by Dr. Askenazi from New York. Again, all conditional. If proteinuria is less than 1 gram, it's steroids and an immunosuppressant. Could be azathioprine, mycophenolate, or calcineurin. But if it's greater than a gram, they want steroids and triple therapy, mycophenolate, and a calcineurin inhibitor. And then if you've got refractory disease, they say check adherence, double check your doses, escalate your treatment from dual to triple. And if it's triple, then consider using an anti-CD20. Oh, by the way, didn't that fail in clinical trials, rituximab? I think they're looking ahead to obinutuzumab, which is more than a year away being approved in lupus from my assessment, or a combination of drugs that could include steroids with either mycophenolate belimumab or calcineurin or an investigational agent. That's it. And they do have a section devoted to kids with lupus nephritis because kids are harder to treat. But I thought that they made this very straightforward. I think they did a great job presenting the data.
Yeah, I think there wasn't any surprise really, was there? I think it was pretty much what you'd expect. Some of the other, I think the interesting the things that of course they can't mention CAR T, they can't mention bikes and trikes. They also can't mention the urine biomarkers, which
Right,
could be
right.
super exciting because who wants a biopsy repeatedly in this day and age? So they're out there, and the good thing is, I think they're going to make everybody feel better because I think this is really what people are doing.
Yeah,
So,
the biomarkers for nephritis are incredibly strong. Andrea Fava presented that again this time. CD168, IL-16, and others in the urine and also in the tissues. That's the way to go in the future, but we got to wait for that to come down the line.
all right. My next abstract is number 995, and I'm just presenting it because I have a confession. So the title is What are the carbon footprints of adalimumab originator and biosimilars? And my confession is I just went there to bust their you-know-whats. I was like,
Wait a
come
second. You're Mr. California, right? Aren't you measuring your own carbon footprint
on.
before you go to work every
Hey,
morning?
hey, I get your carbon footprint right here. Uh, So anyway, what they looked at the available. It's in Europe. These are French, and they looked at 10 biosimilars of adalimumab, and they looked at the carbon footprint mostly of the packaging. So the cardboard and the package insert, and then the device. So is it a syringe or is it a pen? And then they did there. I guess there's some woke software package that allows you to calculate exactly how much that all of these things would represent in terms of CO2 emissions. And they found that there was a difference, maybe as much as a twofold difference among the packaging for the different biosimilars, and that a year treatment with adalimumab pen is 9 kilograms of CO2 per year. So I got to say, I said the poster hall was full. The poster hall was great. I just went there to break chops. I did. Uh,
So, was there a winner in carbon footprint?
The lowest carbon footprint was Amgevita on there, but you should tell you these were all the pens. But you tell your patient to use a syringe. Syringe is a lower carbon footprint than a pen. But I just my confession is I went to the poster, and the poster there was a fellow standing in front of it, and she was a wee little thing. She was, and she looked like the older we get, the younger the fellows get. She looked like she was about 18, and just so earnest and sit. And so I was gonna bust in there and say, "Hey, how did you get to this meeting? Did you walk here? Did you parasail? Did you fly in a jet and get your own carbon footprint? Like, how big is your carbon footprint?" But I couldn't. So I just walked by and said, nice poster.
Marketing for these products has gotten incredibly competitive and difficult. So I firmly expect to be hearing about carbon footprint from my local sales rep. Me, I'm holding out for the prize inside, like we did with what was it,
The
Cracker?
Cracker Jacks.
Yeah, I mean, whoever's got the better prize inside, that's what I'm prescribing. All right. If there was another big buzz item at the meeting, it was the GLP-1 drugs, and there was a lot of presentations in OA beneficial effects, in lupus beneficial effects. We've seen it before in gout, and abstract 2259 was a study of these two different GLP-1 drugs, semaglutide and tirzepatide, which is Manjaro. 152 patients with RA who went on these drugs. They looked at 1 year outcomes, and they all showed significant benefits with weight loss of 7%, BMI decreasing almost 2 to 3 points, SED rate dropping 6 millimeters, CRP dropping 1 milligram per deciliter, lipids, pain, all these things improving on these drugs. Obviously, what goes along with this is better survival statistics, better cardiovascular outcomes. And the question is, what's at what risk and what's it really doing? Only about 15% had GI side effects. About a quarter of the patients had to discontinue drug because of side effects, mostly GI. And is all this from just losing weight, or is there a direct benefit of going after GLP-1 that mechanistically it may make sense? That needs to be worked out in subsequent trials. But I think that if you're a rheumatologist, you're soon to become an expert in weight loss, as you're going to see more and more of these trials in your patients, if not combination trials of these drugs along with your biologics, looking for additive effects.
Yeah, super hot topic, a number of presentations across different diseases. And I think you're right. This is not something that's interesting. I think the only thing holding us back now from prescribing these is the access, is the cost, and the denials. Right now, they're getting a lot of denials. I had a patient who asked for one, and the insurance company told her that if she had a heart attack, they would allow her to have it. It's like, well, you're supposed to prevent a heart attack. But I learned a bunch, and I think you're right. There may be differences. Weight loss is great, no matter how you lose weight, but it may well be that the GLP-1s have an advantage, certainly over the DPP-4s, maybe over the SGL2s in terms of mechanism. They asked me to participate in one of the workshop seminars and gave me the topic of liver disease. So I had to do a lot of work on that. And it was made much easier because now we know for fatty liver disease, which is the most common form of liver disease worldwide for all patients, but we see it all the time in our clinics, don't we? But now we know that the combo GIP, GLP-1 are effective for fatty liver disease. That is absolutely fantastic.
Right.
I think one of the things I learned too is in the seminar on these drugs is eat your vegetables first. That was well, they said when everybody loses weight, then when they stop, they gain weight again. But one of the things you can do is eat your vegetables first. If you do that, it ends up you eat fewer calories. That's my take-home point from the ACR. Eat your vegetables first when you're eating.
I could have gotten that from my mother-in-law, but we went to a big meeting to find that out. Okay, what's next?
All right, the next one I got it's one of the cooler ones, I think, and really gets everybody kind of smiling or chuckling. It was a late breaker, L20, and it's the automated ultrasound machine from Denmark. Arthur is the name, which I love, of course. But and that's been published on. But what they have now is artificial intelligence. So before they had Arthur. Arthur is a robot. So the patient shows up. They put their hand on a tablet, they goop themselves, and the ultrasound probe comes over, goes down, and does an ultrasound. Now they have Diana, which is the artificial intelligence, which is interpreting. Of course, what do we care about? We care about synovial hypertrophy. We care about Doppler activity as a indicator of inflammation. So this was kind of a further proof of this. They had the robot with the artificial intelligence compared to an on-site rheumatologist who was doing it. And then they had a adjudicator who was the ground truth, as they call it in AI studies, who evaluated everyone and saw how well they agreed. The bottom line, the robot did really well. So in terms of agreement on synovial hypertrophy, It was very close to the absolute truth. The Doppler activity also very interesting, very close to the expert who is looking at this. And I think this has a couple of applications. And of course, ultrasound is being picked up a lot, and the fellows are very much interested in it. One of the things that naysayers have against ultrasound is that it's operator dependent. This takes that away. This is now data. And I think in rheumatology, we probably, our bias is probably, well, I don't want the darn machine doing this for me. But, is that any different than when echo was new? The cardiologists did the echoes themselves. Back in the day when it was relatively new, the obstetricians did the ultrasounds themselves. They don't do that anymore. They're done by technicians. So this is essentially even one step further, because you can do it for the hands. You can't do it for other joints. But I think this may be something that you'd see in the future for those consults that there's not enough rheumatologists. No, it's hard to get in to see us. Well, if you go do an ultrasound and you have synovitis, you get in and right then. If you don't, then you probably don't need to see the rheumatologist that quickly. So not perfect, not for all joints, not for deformed joints, but super interesting.
So this adds to other abstracts we've done in recent time, where we talked about finger digital creases disappearing with a swollen joint, and doing that in an automated way with a cell phone. Finger movement as a range of movement done also with a cell phone. These are tools that can be used for remote patient assessment. They can be done to supplant your detailed physical exam. So that could be even in a in-clinic visit as part of a expedited evaluation. And I like it. This one, however, is a little bit slow. It's 20 minutes or more for the robot to do that. The good part is the robot talks to the patient. My, you look lovely today. Is that a new hat? And whatever. And the patients, if for me, it would be bad because the patients might prefer the robot to my personality when it comes to the, conversational discourse. But anyway, I think it's an exciting advantage, and I'd like to see where this goes. And once you show it works well with a robot and a device and whatnot, iterations of that will ultimately get around to using it on a cell phone and seeing how that can be used. So I think this is great progress. So my next one is ianalumab, another B-cell monoclonal antibody, abstract 2580, presented by Meisler and colleagues. Small study, 68 patients with lupus who were treated in a double-blind 28-week placebo-controlled trial, showing the efficacy of this sort of dual depleter of B cells. It does it by ADCC and also by BAFF blockade. Thinking that it's maybe a better depleter of B cells, and maybe that's why in this phase 2 trial it looks so positive. They extended those patients another 28 weeks, so the placebo patients rolled over to get the real drug, and they all caught up in the end. They followed them out to 68 weeks. The good news is that I think that this B-cell targeted agent had very strongly positive results. It seemed to go up with time as you went out further and further, looking at all measures, SRI-4, SRI-6, LL-DAS, DORIS remission, and serologies, all looking well. My only worry is it's a phase 2 trial. And phase 3 is where a lot of good lupus drugs go to die. But so far, the data looks really encouraging here.
Yeah, I think this might fold into the discussion that we were just having about carts and bikes and trikes. And if you have a better B-cell depleter, then might that be something that obviates the need for those other therapies, which, the CAR T, very aggressive, at least certainly for those that require the conditioning regimens and hospitalization. And, that's a very big deal, and the attendant risks of that. So this might be a better option. And boy, so many therapies we have. And of course, the B-cell therapies are being looked at also and in Sjogren's and in scleroderma. So there are a number of abstracts that looked at that as well. And I think it's really the resurgence of that mechanism, and also the resurgence of those diseases, getting much more attention than they ever had.
Yeah.
All right. So my next one, it's I'm going to throw in 1132, which is I think very interesting because it's not even rheumatology. This is the Vega study. It's a follow-up of that. This is the combination of guselkumab and golimumab in ulcerative colitis. And here they looked at the biomarkers. Now, one of the things, advantage that IBD has compared to inflammatory arthritis is that you do colonoscopy and you get biopsies. So you can look at cell infiltrate, you can look at gene expression. So it lends itself to inherent built-in biomarkers. So Vega study is important for several reasons. One is that it, I think, brings back the idea of combination biologic therapy, which had been killed by the earlier negative studies in rheumatoid arthritis, and there's still black box warnings about that. But we saw it in, especially in GI, people would sneak in with putting their toe in the water for people with very refractory disease and adding combinations. But this was a proper study which showed that combination therapy, the idea is not dead. So this is important and it's interesting in ulcerative colitis, but I think we're just a little bit behind it in rheumatology. There's a study called Affinity looking at guselkumab and golimumab in psoriatic arthritis. And there were two other abstracts, 2640 was one and 1460 that looked, one was from France, 1460, the other was from the US, claims data, looking at combinations that people are already using. In the US one, 2640, a lot of people are using biologics and the PDE4 inhibitor. But some people are using the IL-17 and the TNF inhibitor. In the French study, they were combining TNF inhibitors and JAK inhibitors anecdotally. And of course, they're in both analyses, they did find the maybe a little bit more in the way of infections. But these are really, really refractory patients that they're trying this on. So I think super exciting that combination therapy may be making a little bit of a resurgence.
Yeah, I think it's very exciting because it dispels an old myth that we established back in 2000 plus about this combination being maybe dangerous with no benefit. But this is what I worry about. The problem is that who are you going to give combination therapy to? You're going to give it to the patients who have the worst disease. Um, and we had another abstract at the meeting, 1393, about patients with the worst disease are the ones who have the most amount of side effects. And so, which is basically saying that you're set up to lose when you start studying combination therapy or start using aggressive combination therapy in all your failures. Those people are self-declaring themselves to be not just recalcitrant, but more likely to have side effects. And that becomes a worry in the design of these kind of trials. So when you see a real positive result like that, I think we definitely have to look at this data and maybe try to emulate it in some of our diseases, not just in GI. So, there was a lot of, I think if there was another big theme at this meeting was a lot of sessions on steroids. Let's minimize steroids. Let's withdraw steroids. I got two that I want to just give you a quick hit on. One was from Diane Lecaillier, abstract 2673. Her research in using British Columbia claims data, 28,000 steroid users with RA. That's about half their patients with RA. They're on steroids, and they basically looked at what happened to the outcomes. They had, as expected, a fair number of cardiovascular and/or infectious deaths, almost 2,500 cardiovascular deaths out of 28,000, right? And then 387 infectious deaths. And what they found was what we said before in many different ways, that for every year that you were on a steroid, you increase your cardiovascular mortality by 7%. For every year you're on a steroid, you increase your infectious mortality also by about 7%. But what happens when you stop the steroid? Do you ever get back your baseline risk of cardiovascular or infectious death? And it turns out for every 1 year you stop the steroid, your cardiovascular mortality risk went down 1.3%. For every 1 year you stop the steroid, your infectious mortality went down by almost 5%. But the takeaway big ticket item message here was that if you were on steroids a really long time, 3 or 4 years or more, you never get back your baseline risk, meaning what those other people who were just like you, who never got steroids, got back to their risk of cardiovascular infectious death. So the number was, it did not return to normal as regarding cardiovascular mortality if they were on steroids for 2 or more years. It was 3 or more years as far as infectious mortality. If you were on it for longer than that, you didn't go back to the lowest possible number. That is a carryover effect, and that might be through a number of different factors, but kind of eye-opening. Artie, what do you think of this data?
Yeah, so well, it's kind of scary. And after you come back to the meeting and go to the clinic, you start looking at all those patients who are on steroids and like, oh my gosh, well, what do we do? Well, especially for patients for whom the steroids, they know the steroids help, and they're a little bit reluctant to taper. Your PMR patients where you don't have many other options. The rheumatoid patients where they really like that, certainly for flares. And I think there's a natural tendency, because we're human, to kind of kick the can down the road and say, next time we're going to taper. Because you say, let's taper, and they give you the colicky baby face, and you say, okay, next time we're going to taper. But that's how people get on steroids for a long period of time. So these data really kind of scary, honestly. But I think, now we have so many therapies, even in conditions like PMR, where you're some like very exciting data of things other than steroids. So I think, we see data like this, and it's like, hey, we got to get our act together and, get steroid sparing.
I know we got to wrap up, but I want to add on to this discussion. Peter Merkel in a plenary session 0774 presented data in GPA patients where they were in remission, and on 5 milligrams of prednisone, they either tapered them or they kept them on. If you kept them on the steroids, you got more flare rates. Not so much if you were on a background of rituximab. It was like 9% versus 6% more, but not statistically significant. But if you were not on background rituximab, it was much higher, 20% versus 2.6%. And all the flares were minor flares. The point
Yeah.
being that it's probably good to stop the steroids. And there were a lot of other sessions devoted to this. Artie, let's do one more each.
Okay.
Quick hit, what do you got?
Quick hit. I got 1745, and this was the oral surveillance and statin use. We're all very familiar with oral surveillance. There have been multiple publications, dozens of abstracts. I think the data is something we know and we understand. I like this one because the point was to look at statin use, which they had done. But this, I think, has an important message for us, and that is we're kind of underutilizing statins, and across all of our diseases, this is an RA, of course, in the oral surveillance, but across all of our diseases, we're underutilizing them, really underutilizing them. But if you add statins, you can decrease the risk. Remember, in the study, there was a higher risk of MACE with TOFA compared to TNF inhibitors. But if your patients are on statin, the difference dissipates. So maybe we need a cocktail for our patients of a GLP-1 and a statin, and maybe a little naproxen thrown in or something. But I think these data are sort of telling us we just can't ignore it and say, go talk to your regular doctor, especially in our younger patients who don't maybe go see their regular doctor.
Again, this does go well with the data. It shows that we and other doctors are not very good at health maintenance things, and that we really do need to step up and make sure our patients are on these therapies. The important question came up in this session for those people who you would not use a JAK inhibitor because of their age or because of hyperlipidemia. What if you treated them? Would you now make that, does the equation change? Would you now consider using a JAK inhibitor in those people or continuing it when they previously had success? I think based on this data that Dr. Giles presented, I would. My quick hit is it's called the PMR mode study, abstract 1697. It's a 1 year study of methotrexate or placebo in recently diagnosed PMR patients who had received less than 8 weeks of glucocorticoids. And the endpoint here was glucocorticoid-free remission at week 52. 64 patients, but when you looked at their progress over 52 weeks, the lines are superimposable, meaning placebo did just as well as methotrexate. And this has kind of always been the argument in these PMR patients where you're trying to steroid spare. Can you use methotrexate? And we often do for lack of having options. Now that we have sarilumab and other drugs coming down the line, I think that, it makes sense. And by the way, secondary outcomes were no different between methotrexate and again, 25 milligrams per week is not a dose issue. You could have said, well, maybe the cohort didn't have inflammatory enough disease. You could make that assumption, but there was another abstract at the meeting, abstract 1700, that did a claims data of people with PMR going on either sarilumab or methotrexate that they matched up as best they could, 210 per group, and sarilumab outperformed 60% versus 35% as far as the endpoint of being off of steroids within 6 months. So I think this is, this is changing the conversation on steroid sparing in PMR.
Yeah, I think this is maybe the most important abstract of the meeting, or maybe not most important, but the most impactful because we go back to the clinic. I'm in the clinic right now, and your PMR patients, and we always like abstracts that agree with us. I've never been a methotrexate believer, but you look at the data as it is until now. The believers can say, well, there's something. The non-believers can say, nah, there's nothing. I think this is super clear. As you said, you can't say, well, you didn't give a high enough. And you can say, well, it's only 62 patients, but you could have had 6,200 patients, and there was no way that there was going to be any difference. The lines are exactly the same, saying that I don't think there's a point giving methotrexate to PMR patients. When I have fellows here, I'll say, some PMR patients may have peripheral arthritis. They're very RA-like. For them, maybe, but don't treat your PMR. Don't delude yourself that you're going to use methotrexate as a steroid sparing drug. And I think, boy, this was super clear data, and this is very, very impactful, very useful in the clinic, like now, today.
So I want to thank the audience for, again, hanging with us in Rheumatology Roundup again this year from ACR. ACR next year, Chicago. We're going to be there. We hope that you'll be following us or be there with us for another great meeting. The next two big things that are going to happen in rheumatology are big rheumatology meetings, one in Maui and one in Dallas. Artie, what's going on in Maui in February?
Rheumatology Winter Clinical Symposium. So, place to hear about the latest data and, chat about it with friends and colleagues in a collegial atmosphere.
Yeah, 11 through 15. Artie and I will be there. We'll be doing our wrap up on all RA abstracts, and Artie will be doing wrap up on SPA, and the faculty and program looks really, really good. r-w-c-s-.com. Got to put dashes in there, and check out the agenda and faculty. You'll be surprised. And then and that's February 11th through the 15th. Right before that in Dallas, February 8th and 9th, Room Now Live 2025. Early bird pricing it goes away, I think, on the 30th or December 1st. If you go there and check out the agenda and register and put in the code ACR 2024, that doesn't make sense, does it? It might be ACR 2025. Either one to get the early bird discount, okay? But that's Room Now Live. Again, another great meeting, day and a half meeting. Artie's got a great 4-day meeting. Ours is a Saturday, half-day, Sunday meeting, whichever fits you. And you can, by the way, do this virtually if you like.
Or do both. Great meeting. Room Now Live will be a great meeting and local for a lot of people. Really easy to get to Dallas. So,
all right, Artie, thanks for doing this. We'll see everybody next year.
Thank you.
Over and out.